Pediheart, Pediatric Cardiology Today. My name is Dr. Robert Pass, and I'm the host of this podcast. I am Professor of Pediatrics at the Icahn School of Medicine at Mount Sinai here in New York City. Thank you for joining me for this 345th episode of Pediheart. I hope everybody enjoyed last week's episode on the topic of ablation procedures in the postoperative period. For those of you interested in postoperative management as well as electrophysiology, I'd recommend you take a listen to last week's episode 344 with Dr. Audrey Dione. As I say every week, if you'd like to get in touch with me, my email is easy to remember. It's pdheart@gmail.com. This week, we move on to the world of congenital heart surgery. The title of the work we'll be reviewing is Outcomes of Neonatal Cardiac Surgery, a European Congenital Heart Surgeons Association Study. The first author of this work is Claudia Catapan, and the senior author, Vladimiro L. Vida. And the authors come to us from multiple centers in Europe. Dr. Catapan and Dr. Vida come to us from the University of Padua. When we're done reviewing this paper, I'm excited to say that Dr. Vida will be speaking with us all the way from Italy. Therefore, let's move straight on to this article and then a conversation with its senior author. This week's work begins with a number of comments about critical congenital heart disease and how this form of disease, whereby an intervention is required early in life, accounts for roughly 1/4 of all congenital heart defects. They then point to the many factors that lead to higher risk in performing procedures like cardiac surgery on this patient group, such as prematurity, smaller size and anatomical structures, and just plain fragility of small patients. And they explain that despite massive advancements in the care of this patient group, 30-day mortality for this patient group undergoing surgery is significant. They point to a 2022 paper from Egypt and Saudi Arabia that demonstrated 9% 30-day mortality rates and 11% in-hospital mortality rates. With this as a background, the authors explain that the aim of this study was to comprehensively assess the characteristic of patients and outcomes associated with neonatal cardiac surgery from 2013 to 2022 in hospitals associated with the European Congenital Heart Surgeons Association, or ECHSA. This was a retrospective multi-center study using data from the congenital database of the ECHSA, focusing on patients who had surgery less than or equal to 30 days of age in the 10-year period from 2013 to 2022. The authors review how the data in this database is quite robust and is verified for accuracy. They identified 12 benchmark surgeries, and these were Norwood procedure, hybrid palliation for single ventricle, isolated arterial switch operation with VSD, arterial switch operation and arch repair, aortic coarctation performed via lateral thoracotomy, aortic coarct repair using bypass, presumably via sternotomy, isolated interrupted arch, aortic arch repair associated with another procedure, truncus repair, any kind of shunt such as an RV to PA conduit or an aortopulmonary shunt, and finally, total anomalous pulmonary venous repair. The authors used multivariable logistic regression models to determine which factors were associated with 30-day mortality and in-hospital mortality. The benchmark operations were divided into 3 subcategories based upon the stat category, and these were Category 1 being Stat 1 to 2, Category 2 being Stat 3 to 4, and Category 3 being Stat 5. The authors also looked at many other covariables, including things like surgery, sex, age less than 10 days at the time of surgery, other non-cardiac problems, weight less than 2.5 kilos, use of cardiopulmonary bypass or circulatory arrest, ECMO needed before or after surgery, and many other factors. And on to the results! Well, there are many data in this very large-scale work, and as usual, I would encourage those interested to read this work, and the link, as always, will be in the show notes. There were 30,931 neonatal operations in the time period, but after excluding procedures not in the targeted analysis, there were a total of 22,763 neonates from 97 centers across 36 countries that participated in this work for analysis. The 4 most common procedures were arterial switch operation, isolated coarctation repair, a shunt procedure, and the Norwood. PDA closure was included in the other category and accounted for 8% of neonatal heart surgery. Looking at non-cardiac diagnoses that were seen, the most common was trisomy 21, accounting for 1% of all surgical candidates, and 22q11 in 0.93%. The authors explained that truncus arteriosus patients had the highest percentage of non-cardiac disease in 12.8%, and the most common non-cardiac disease in the patient group of truncus arteriosus was 22q11 deletion, accounting for nearly 75% of the non-cardiac disease in that cohort. And so to recap the four most common procedures performed, they were the arterial switch operation in 15.5%, coarctation repair in 14.1%, shunt procedures in 10.3%, and finally the Norwood procedure in 9.2%. The 30-day mortality for the entire group was 5.9%. It was 3.3% in the arterial switch operation, 16% in the Norwood operation, and 15.4% in the hybrid operation. In-hospital mortality overall was 9.1%, and it was 4.1% for the arterial switch patients, and 25% for the Norwood, and 31% for the hybrid procedure. Cardiopulmonary bypass was used in 64% of patients, and the longest cardiopulmonary bypass times were seen in descending order, first in the arterial switch operation with arch repair, where the median was 249 minutes, the arterial switch with VSD closure, where the median was 185 minutes, followed by the Norwood, where the median was 186 minutes. Aortic cross-clamp was used in 59% of patients, and longer cross-clamp times were associated with the arterial switch operation with arch repair, 146 minutes, and arterial switch operation with VSD closure, where the median was 111 minutes. Perhaps not surprisingly, Norwood operations and arterial switch with arch reconstruction were the operations with the highest frequency of postoperative complications at 62% and 55% respectively. Postoperative ECMO was used most commonly following the Norwood, where it was employed 19% of the time, and the arterial switch with arch repair in 11%. The median postoperative ICU stay was 6 days, and longer ICU stay was seen in the Norwood patients, where the median was 13 days, and hybrid procedure where it was 11 days. The median length of stay for all patients was 26 days, with the longest postoperative stay being 29 days for Norwood patients, followed by hybrid of 23 days. And so to re-emphasize this important point, which surgery had the highest mortality rate? Again, it was the Norwood operation with a 30-day mortality of 16% and an in-hospital mortality of 25%, followed by the hybrid operation where the 30-day mortality was 15.4% and in-hospital mortality 30%, followed by truncus arteriosus repair with a 30-day mortality rate of 9.5% and an in-hospital mortality rate of 16.3%. In Table 3 on page 885, the authors demonstrate that when looking at the operations by stat category, the in-hospital mortality and 30-day mortality rose when going from Category 1, which you recall is Stat 1 and 2 cases, where in-hospital mortality was 4.7%, to Category 2, which again were Stat 3 and 4 category cases, where the mortality rate was 9.5%, and finally the Stat 5 category, where the mortality rate was 25%. Using a multivariable model, as mentioned previously, the authors determined that the major factors affecting mortality were higher risk procedure, meaning higher risk category, with an odds ratio of 2.74, and the need for ECMO, where the odds ratio for mortality was nearly 12. Interestingly, when the authors divided the operations by era, separating the group into the first 5 years versus the last 5 years, there was no statistically different rate of mortality observed. In their discussion, the authors state that these data reconfirm the notion that neonatal cardiac surgery continues to pose significant challenges for multiple reasons. They reference a paper from 2010 from this same organization showing that the mortality rate then was 9.1% and it was 5.9% in this work, suggesting improvement in outcomes globally. Despite this, the authors bemoan the fact that some of the more challenging or high-risk procedures, like Norwood's, had similar outcomes today to back then. They mention prior works by the STS also demonstrating high mortality rates for the Norwood, and mention that the all-in in-hospital mortality of 16% for the Norwood and 30% for the hybrid highlight the need for continued innovation in the management of these patients. They explain that their multivariable analysis showed that the presence of non-cardiac disease increased the risk of 30-day mortality and in-hospital mortality, as well as smaller and younger infants, as has been previously demonstrated. In regard to limitations, the authors mention the profound variability in surgical techniques, postoperative care protocols, and patient populations over such a diverse group of centers, which may impact the generalizability of the findings. The authors conclude this work by stating, and I quote, Our analysis of a large multi-institutional cohort of neonates who underwent cardiac surgery during the last decade in centers affiliated with the ECHSA provide new insights related to the characteristic of patients and outcomes of neonatal cardiac surgery in Europe, and documents decreased mortality compared with previous epochs. These data can be used to provide valuable benchmarking across Europe, identify opportunities for improvement, and facilitate parental counseling. Accompanying this work is a very brief editorial by Dr. Jennifer Nelson, who is a cardiovascular surgeon at Nemours Children's Hospital in Orlando, Florida. I won't review the entire comment, but she wonders aloud if her general impression that mortality rates for single ventricles are higher in this European study are in fact higher than in the STS studies that have been previously published. She freely admits that how the data are reported are different from prior STS reports, and in some regards this may be a situation of comparing apples to oranges, but she does raise this point. She wonders if the known higher rates of termination for pregnancies of single ventricle patients in Europe play a role, with the implication being that these cases are therefore going to be less common, resulting in lower levels of experience in these complex operations for the surgeons in Europe. She wonders what relation detection rates in fetal life have to outcomes, and suggests that more international studies on this topic are needed to ferret out risk factors, and suggests that a focus on hybrid and surgical stage 1 palliation approaches are needed. Well, this is an interesting work in that it sort of gives the reader a general benchmark against which programs in Europe can judge their outcomes, while also clearly demonstrating that there is much room for improvement. I do find it interesting that there was no obvious difference in outcomes for single ventricles undergoing single ventricle palliation over the 10-year period, despite what we perceive to be improvements in care. I also was interested to see these mortality figures and have similar questions regarding why it may be that these outcomes may be slightly worse than those reported in the United States. I've always had a suspicion that there are differences of opinion in general regarding the management and approach to these patients, but this is clearly very difficult to prove. I wonder if there is any evidence that larger centers had improved outcomes versus smaller ones, as has been sometimes suggested by data from the STS. In the interest of time, I think we should move forward to our conversation with the work's senior author, Dr. Vida. Joining us now to discuss this week's work is the work's senior author, Dr. Vladimiro Vida. Professor Vladimiro Vida completed his medical studies at the University of Padua in Italy. He completed his cardiac surgery residency in Italy, followed by a 2-year clinical fellowship in Guatemala under the guidance of Professor Aldo Castaneda, and then spent an additional 2 years at Boston Children's Hospital, Harvard Medical School. Following his training, he was appointed as a consultant at the Pediatric and Cardiac Surgery Unit of Padua. In 2017, he became Associate Professor of Cardiac Surgery, and subsequently in 2019, he was promoted to Full Professor of Cardiac Surgery, where he is now the leader of the Pediatric and Cardiac Surgery Unit of Padua. It is indeed a great honor and pleasure to have him join us this week to discuss this week's work. Welcome, Dr. Vida, to Pediheart. I'm here now with Dr. Vladimiro Vida, who's speaking with us all the way from Padua, Italy. Dr. Vida, thank you so much for joining us this week on Pediheart.
Hey, thanks so much, Robert, for inviting me. It's a privilege.
A real privilege and honor to have you. You know, Dr. Vida, I was wondering if you could start by just sharing with the audience what were the main motivations for you and the ECHSA for reviewing these neonatal cardiac results as you do in this work.
So, Robert, as you know, ECHSA own the largest congenital cardiac surgery database in Europe since 25 years, and now this database is pretty big and accounting for more than 320,000 patients and 380,000 procedures on pediatric and congenital cardiac operation. Wow. So this kind of enormous volume of data has been used for scientific support, especially for rare conditions which are not frequently encountered even in larger centers, but also to support benchmarking and center quality improvement initiative. Also important for physicians to individualize their practice and care decision. So the primary motivation for this ECHSA study and myself was to conduct a kind of comprehensive assessment of the characteristic of patient in the neonatal age group and outcomes in a decade, 2013-2022, within hospital associated with ECHSA. And the main idea was to comparing the data from this decade to a previously published study from ECHSA, which was done, considering another decade, 1999, 2008, which was also published in the Annals of Thoracic Surgery. The idea of reassessing the outcome 10 years later was driven by the desire to investigate if there was any, improvement in the management of congenital heart disease in Europe. And also, that neonatal cardiac surgery is highly specialized and an evolving field. We wanted to determine if, advanced in surgical technique can have an impact, on the postoperative care result within Europe.
I see. Thank you very much. Dr. Vida, your paper has so many results, and again, I want to encourage all who are listening to the podcast to read the paper. A link to the paper will be in the show notes of this week's podcast. But among the many findings of your work, I sometimes will ask the author if you might share with the audience what you, as the senior author, were most surprised about to discover when reviewing this really gigantic database that you're reporting on.
Well, yeah, Robert. Actually, in a comparison, with the previous study, comparing two different decades, we are surprised, but we have a kind of similar distribution of procedure. So there were no, a procedure upon another, during the last decade. But what we noted is that we have a significant decrease in hospital mortality, actually 30-day mortality rate, which now currently account for 5.9% compared to the 9.1%, almost, half of the mortality in the neonatal period. Well, given the significant advancement in pediatrics during the last few years, we were impressed, because maybe the refinement of surgical technique and the improvement of postoperative outcome can enhance, the possibility of having, different results. However, although the overall operative mortality associated with neonatal cardiac surgery within ECHSA was improved, certain procedures, especially the one undertaken on single ventricle hearts, the Norwood operation or the hybrid operation for HLHS, continues to be associated with significantly higher mortality rate. And these findings compel us to kind of reevaluate what's going on here. Why all is increasing but not this patient. So this is kind of a big question mark, and is a future opening towards other studies.
Yes. This dovetails very nicely with my next question, which is, you did find, just as you so nicely pointed out, that the Norwood cases didn't seem to have a very significant change in mortality. And I'm wondering, did this surprise you? You talked about how improvements have come in many aspects of surgical care, both in the operating room and in the post-op period, but in that particular patient group, the mortality risk for the highest risk cases didn't really change very much. Did this surprise you? And do you have any thoughts regarding why there wasn't a significant observed change in outcomes for Norwood's over a 10-year period?
Actually, it's a keen observation, and in our discussion, we pointed out, actually that also we didn't expect, we tried to expect an advantage over the years, but actually, even if we split the 10-year period into separate 5-year period, we didn't find any difference, And I guess that even the Norwood is a kind of a well-codified procedure within the cardiac surgery world, I think 5-year period simply isn't a sufficient time frame to have kind of a definitive changes within, the operative mortality. So I guess that surgical innovation, improved, but maybe for other pathology, not for ventricular heart, where you have a complex physiology, complex postoperative course, and also the other innovation science, since we didn't find any difference between the type of shunt we utilize, RVPA versus BT.
Yeah.
In North America, you had a great, SVR trial where you compare both and you find different results, but actually the results were similar for us. And I guess that what we found is that within our time frame, there were no changes, but there were some changes within the previous decades with a 10% reduction in mortality. So actually, we improved results, but still, this kind of pathology for univentricular malformation treated by, the pathway of the Norwood operation or the hybrid procedure still remain very, very high.
Yeah.
And this is a kind of very interesting thing to point out.
Yes, yes. Well, prior works, largely in the U.S., have suggested that higher volume centers have better outcomes on average with some of the more high-risk surgeries such as Stat 4 or 5 category operations. Did you analyze this to any degree in your cohort, and do you have any observations regarding outcomes in European centers that had larger or smaller volumes?
Well, you touch upon, kind of a crucial point, within the realm of complex cardiac surgery, because what we call volume outcome relationship or center effect is something that we analyze actually. In our cohort, we conducted a dedicated sub-analysis to investigate this phenomenon, the center effect. And what we found was a positive correlation between the center volume and a better outcomes for patients. This aligned with other hypotheses or other study that previously published this relationship with high volume center and better result. However, I think that there are a few limitations to take into account, and also there are several publications recent from some other U.S. center where actually they demonstrate the opposite.
Yes.
I think that the limitation is that we have a high number of center included in the data insertion within the database, and actually there is a lot of variability, heterogeneity between different centers. We have different internal resource allocation, specific approaches to patient management. So it's very difficult, even in large center, to find something which is very consistent during the years. And also we covered a 10-year span of surgical treatment in Europe. And this can also add other changes, because not all the center consistently insert data through the 10 years, and also this can expose to another variability. So in other words, the center effect still have a positive value, means that you need to concentrate, a large amount of volume, maybe especially for very complex pathology like the univentricular heart in some centers, that to try to increase result. But we found that there are a lot of limitations. So it's good to concentrate, but sometimes you have a small center with less heterogeneity of treatment and the better results than bigger centers. So it's difficult to find the real solution.
Yeah. Well, for those in the audience, it is actually quite late at night in Padua. Dr. Vida was nice enough to speak with us after a long day operating. Here in New York, it's only in the late afternoon. So I'm going to finish up with the last question. We just talked about the single ventricles, and you are obviously a very experienced surgeon. And based on your experience, your knowledge, and the analysis of these data, I'm wondering if you have any insights into possible actionable interventions that can be made to improve single ventricle outcomes in Europe. You talked about center effects and potentially cohorting them into certain centers. Any other thoughts on how to improve these outcomes, given that this one little area, although all the surgeries were generally better outcomes in the last 10 years, this was the one area where there wasn't as much improvement. Any thoughts on how maybe not only in Europe but everywhere these outcomes could be improved?
Well, I guess this is a kind of a very difficult question to answer,
Yeah.
But I had some experience, in talking with other friends from, the STS, which is, your association, big association in the US. And actually, when I'm talking about, study from the STS database, they're talking to me about, a different range of mortality within the US, which ranges between 11 and 15%, which actually is much less than what we had in Europe.
Yes.
Even for Norwood operation, and also for stage 1 procedures. I guess that you have a different regional phenomenon possibly influencing Norwood outcome in the US because, as you know, in Europe we have a higher rate of pregnancy termination, which is due to an increase prenatal diagnosis, which is mainly for very complex congenital heart disease, brings to the interruption of pregnancy, and this is contribute to decrease the number of cases per center and the load volume for each center in dealing with these special particular anatomies. Yes. However, I think that we are now trying to get in touch with the STS because I believe that a future comparative study between the STS database and the ECHSA database, we actually are the two largest database in the world about congenital heart disease, can allow us to understand maybe the difference in treatment, in anatomy, in indication, and in the postoperative treatment. We possibly can align, the European system to the US system. There were a lot of different surgical strategies that changed the world of treatment for ventricular heart. The Sano shunt and other like the hybrid procedure, which is particularly in low birth weight kids or with other extracardiac anomalies, can increase the result, even though we notice that these are the worst case, because usually present very unstable, low birth, very other pathologies. So in my mind, we need to learn, from each other. So I guess that conducting some, combined study, combining different reality within the US and Europe can help in the alignment of treatment and also possibly ameliorating the results for this, special and very complex congenital heart disease, which still affect, our minds because it's the most difficult pathology to treat. And I guess these kids need to have a great consideration in our effort to improve the quality of the treatment we are offering to our patients.
Yes, all very interesting and important points. And I think actually Dr. Nelson in her editorial comment talked about possibly doing exactly what you just suggested, which is to do some comparative work with STS and try to figure out why there are differences. And there may not be differences, actually, because you're measuring it slightly differently than they are, but definitely is worthwhile, I think. Well, Dr. Vida, I can't thank you enough for joining us this week on the podcast. It's been a great honor to have you, and I want to congratulate you and your many, many co-authors and the many, many centers in Europe that participated in this registry study. Really a wonderful work. I can't even imagine all the work that went into creating this paper. I think some people would have turned this into 6 papers. There's so much data in it, but I really appreciate your time, and again, congratulations.
No, for me it was a great honor and a great experience to stay with you in this podcast. Thank you for allowing me to participate. I will thank all the co-authors that helped me in doing this job, and hope to see you in the near future.
Thank you so much. Well, I'm sure you gained a lot from listening to Dr. Vida. I think he offered a number of important points regarding his data set, and I find that his final comments about potentially doing work with the other gigantic congenital heart surgical database, that of STS, to be especially exciting, both to better understand outcomes and to also help both organizations with quality improvement efforts. Off-air, Dr. Vida shared with me the wonderful time he had learning under Dr. Castaneda during his year's training in Guatemala. I can't imagine how wonderful it must have been to learn from that giant and operate with him, but we all know how wonderful a surgeon Dr. Castaneda was, and Dr. Vida shared with me how Dr. Castaneda taught him the difference between being a chief and being a mentor. And certainly in saying that, his comments echo those by many who were lucky enough to work with that master of surgery, including Dr. John Lamberti, who spoke to us a bit about Dr. Castaneda and the important role that he played in his training 40 years earlier, back in podcast 225 from 3 years ago in 2022. As Dr. Vida was uncommonly clear in his comments, I won't add any more, other than to thank him for taking time from his very busy schedule to speak with us this week on Pediheart. To conclude this 345th episode of Pediheart Pediatric Cardiology today, we hear the wonderful Italian soprano Rosa Feola sing the beautiful song by Gastaldon, Musica Prohibita. Miss Feola is becoming a giant star in the world of opera, and she started her career in Italy, having been born in San Nicola la Strada in Caserta, Italy. She has sung at most of the great opera houses of the world, including here in New York City at the Metropolitan Opera, and has starred in many of the great operatic soprano repertoire. It's easily apparent why she is so valued in the world of opera, hearing her beautiful voice in this lovely, famous Italian song from the late 1800s. Thank you very much for joining me for this episode, and thanks once again to Dr. Vida. I hope all have a good week ahead.